to the first edition of Crossing Kynsey Road, a clinical society podcast. This is the official podcast channel of the University of Colombo Clinical Society. A little bit of history for our listeners. Founded in 2018, the UCCS was born from a vision. That is to shape tomorrow's clinicians to not just competent doctors, but also dynamic thinkers and compassionate leaders. This podcast channel is the next step of that journey, where we explore medicine beyond textbooks through conversations directly from Kynsey Road.
Crossing Kynsey Road, a clinical society podcast, features conversations between doctors and medical students. Views expressed are personal and do not represent affiliated institutions. Content is for educational and entertainment purposes only and does not constitute medical advice, diagnosis, or treatment. Cases discussed are fictional, and any resemblance to real people or events is purely coincidental. The speakers have no financial or other conflicts of interest to disclose.
I'm Visal Pereira, a fourth-year medical student, and today we're joined by a very special guest, Dr. Sarit Ranavakar, Registrar in Internal Medicine at the National Hospital of Sri Lanka, a past president of the UCCS and one of its founder members. Welcome to the show, Dr. Sarit. It's wonderful to have you here.
Hi, Visa. It's wonderful to be here, and thank you for that kind introduction. And so this is a very exciting time for the University of Colombo Clinical Society, and I'm very happy to be part of this debut episode of the Crossing Kynsey Road podcast. So thank you for that.
Yeah, I'm very eager for our audience to know you a little better. So besides the daily medicine grind, what have you been interested in lately?
So as you said, I'm a registrar in internal medicine at the National Hospital of Colombo. So most of my time is, most of my time involves being a registrar. But whenever I'm free, I do have an inkling towards jazz music. I listen to a lot of jazz, and I'm a pathological, I have a pathological addiction to aircrafts and aviation. And whenever I have some free time, so I like to do some street photography as well. So these sort of involve my time when I'm not a registrar.
Right. So, and you're a guitarist as well.
I try to be.
Right. So I'm sure you'll agree that, chest pain is sort of the bread and butter of the everyday physician. Ischemic heart disease continues to be one of the leading causes of mortality and disability-adjusted life years, especially in our part of the world, in low-middle income countries like ours. So today, in today's podcast, we turn to acute coronary syndromes, where we will talk about its classification, risk factors, some ECGs you cannot miss, and principles of management.
Yes, so you're absolutely right. It is the bread and butter of being an internist, and hopefully we can give us some good tips and some pearls of acute coronary syndromes.
Yeah, so today's discussion will be split into two parts. The first part will be on introducing ourselves to the lesser known concepts of ACS and how to come to a diagnosis of ACS, including a small discussion on troponin kinetics. And the next part, which will be uploaded in a future episode, will focus more on the principles of management. Right, with that out of the way, let's follow Dr. Sarit as he encounters Mr. Soisa, a 40-year-old clerk working long hours at a private firm. He is the father of 2 preschool-age children and the sole breadwinner of his family. He has a known history of diabetes, hypertension, and hyperlipidemia for the past 5 years. He now presents with severe central chest pain, described as a tightening sensation. This pain started at rest about 2 hours ago, and it is accompanied by sweating and vomiting. He is conscious but clearly in pain. On examination, his blood pressure is 150/100, his pulse rate is 110 beats per minute, and his lungs are clear. Right. So when a patient like this walks through the door with chest pain, our first instinct is to usually exclude something sinister, like an MI. How would we approach chest pain as a symptom of acute coronary syndrome?
Right. Acute coronary syndrome is a very important differential, as you said, because it accounts for a lot of disability adjusted life years as well as mortality is one of the leading problems in the world of medicine. And it's also important to keep in mind that acute coronary syndromes is not the only thing that can be very sinister. So, for instance, you need to differentiate it out from things like aortic dissection, pulmonary embolism, and you need to first diagnose that anatomy. So that chest pain can originate from even the surface of the skin, like herpes zoster rash, up to the level of the visceral organs, such as even the lungs. So it can even be a pneumothorax. But this nature of the pain will help you do that. So something that is central or towards the left side of the chest, especially worsening with exertion and associated with autonomic symptoms such as sweating, would really make you think that this is possibly cardiac in origin. So it's important to arrive and exclude the important differentials, as I said, which we are not going to get into because the conversation is to be ACS today. But you have to keep in mind that there are other sinister things that you have to exclude. So once you've done that, once you've anatomically thought out this to be cardiac, then the next question is this an acute event, or is this something that had been sort of developing over some months or years, suggestive of a chronic coronary event? So to discriminate that, one key factor is whether the chest pain occurs at rest or whether it's predictable. So something that is predictable, occurring after some strenuous exertion, and is suggestive of a chronic coronary syndrome. So an acute coronary syndrome is usually occurring at rest when somebody does not expect it. So it's unpredictable pain, and usually this sort of pain lasts more than 20 to 30 minutes. So in the presence of those factors, you need to think of an acute coronary event over a chronic coronary syndrome. But as we know, sometimes chest pain can be very tricky. So not all patients will come out with that typical description of chest pain that we talked about right now. So it's important to keep in mind that especially in the elderly and those with diabetes, and sometimes there's some evidence say that the females or women might come out with atypical forms of chest pain that does not necessarily exclude obstructive coronary artery disease. So I just want to take this opportunity to talk about some history with regards to chest pain. So it's very interesting. So I had to read about this because we are talking about acute coronary syndromes today. So the first account of chest pain being of cardiac origin, even though it seems quite obvious to us now, was actually first put forth by Dr. William Heberden. So that had been in 1768. So he had presented this paper at the Royal College of Physicians in London, where it was an analysis of about 20 patients. So it had been called Some Account of a Disorder of the Breast. So he had coined the term angina pectoris at that time. And the description that he had given during this presentation is absolutely wonderful. So I just want to read it out to you word for word, so that because I really want to take this out. So what he had mentioned is there's a disorder of the breast marked with strong and peculiar symptoms, considerable for the kind of danger belonging to it, and not extremely rare, which deserves to be mentioned more at length. The seat of it and sense of strangling and anxiety with which it is attended may make it not improperly be called angina pectoris. They who are afflicted with it are seized while they are walking, more especially if it be uphill, and soon after eating, with a painful and most disagreeable sensation in the breast, which seems as if it would extinguish life, it were to increase or to continue, but the moment they stand still, all this uneasiness vanishes. So this gives out a very good description of about how, it's that strangling sensation and that sensation of impending doom, and also the exertional nature to it, and how it relieves with rest. So I found this to be quite wonderful, and so he had been fundamental in describing many other symptoms and signs, so including Heberden's nodes and tuberculosis of the hip. And so after 4 years since he first described this in 1768, one person, I believe it was a doctor, had actually been experiencing these symptoms, and he had wanted them to do an autopsy on him, if at all he died. So in 4 years later, in 1772, they have actually done an autopsy, and then what Heberden had said was, since it was not due owing to any malconformation or morbid destruction of parts necessary to life, we need not despair of finding a cure. So the autopsy had been negative, and they had been fairly, it was a mysterious pain, so they did not know what to do with it. But since it was not very obviously a problem with the autopsy, they had said we need to investigate this more, but there's no urgency to find a cure. But it had been said that they had never looked at the coronary arteries,
Right.
so during the autopsy. So then there had been further investigation into the coronary arteries, and then it was later found out that this sort of pain is actually attributed to obstructive coronary artery disease. So yeah, I thought that is quite wonderful.
Right. So, yeah, I think you touched upon like Heberden's description, which is, I think, what we all learn as the typical chest pain. But as someone who has done multiple medicine appointments, chest pain is definitely not very typical when it presents in the real life patient. So how do we determine what type of atypical chest pain requires an investigation into ACS?
Right. So you are again very much correct when you say that not all chest pain, not all acute coronary events present, or not all obstructive or non-obstructive coronary artery disease present with that typical description of chest pain. So you need to be able to put the patient in the correct context for you to make sense of it all. So somebody with many vascular risk factors, and accounting for their age. So as I said, older people, especially with diabetes, may not have the usual autonomic symptoms that you associated with a typical chest pain. So, and there is enough and more evidence to say that women with may present with atypical symptoms, and this is one of the causes for misdiagnosis of ACS in the female population. So, and sometimes things that we usually tend to associate as atypical pain, such as right shoulder radiation, is in fact, if you take the positive likelihood ratios, radiation to the right arm or shoulder has actually a greater positive likelihood ratio than radiation to the left arm. Yeah. So sometimes what we think is supposedly atypical is actually quite concerning. So one easy way to sort of get around this whole thing is to use a risk factor weighted clinical likelihood score. So, and that is exactly what the European Society of Cardiology also advocates and endorses in their guidelines. So one such very well multi-center validated score is what you call the heart score. So I would direct you to a very interesting episode by the JAMA Rational Clinical Examination podcast series with regards to the heart score and how this is helpful in sort of navigating this whole problem with non-typical chest pain. So yes, the key thing there is chest pain is not always typical, but in the correct, you need to put it in the correct context for you to make sense of it all.
Right. And so the heart score, can I ask what it comprises of?
Yes. So I won't bore you with the details. So, but it's very easy. So the heart is actually an acronym. So you can remember it as history, the EKG or the ECG changes, the age, risk factors, and then troponins. Yeah. So the heart score involves all these components to make a better estimation about what is the risk that this patient is having an acute coronary or chronic coronary event.
Right. So, like early in our discussion, you mentioned the terms chronic coronary syndrome and acute coronary syndrome, and you told us a little bit about how we could sort of clinically differentiate them. Are there any sort of pathological differences between these two as well?
Yes. So we've seen some changes into the nomenclature over the last few years. So previously we used to talk about stable angina and acute coronary syndrome. But I think we now realize that there is nothing very stable about stable angina at all. So since somewhere around 2019, this term was changed to chronic coronary syndrome, and the counterpart of that being acute coronary syndrome. So this is, as you said, based on the underlying pathology. So when you take acute coronary syndromes, the biggest or the culprit is an acute plaque change. So this is either a rupture of a plaque or a thromboembolus being shot up from somewhere else, going into the coronary arteries and rapidly occluding the coronary artery. So as compared to chronic coronary syndrome, where what you see is a progressive stenosis of a vessel over years of atherosclerosis. Yes, both these are very much linked to atherosclerosis and atherosclerotic cardiovascular diseases, but the event that initiates this issue is very rapid in acute coronary syndromes as compared to a progressive stenosis of vessel in chronic coronary syndrome. So when you take the subclassification of acute coronary syndromes, you can further subclassify, as you may all know, to unstable angina, non-stable elevation ACS, and ST elevation ACS. But it's also very important to keep in mind that not all acute coronary syndromes are due to obstructive coronary artery disease. Right. So there can be many other causes. So the fundamental problem here is a mismatch between oxygen demand and oxygen supply. So there are so many other modalities or pathologies in which they can still sustain an acute coronary event or a chronic ischemia to the heart that is not limited to obstructive coronary artery disease. So there's great interest in reshaping this terminology in the coming years.
Right. So there is possibly going to be a new terminology that will come into play in the future.
Well, there has been a new proposed reclassification or sort of renaming this thing of acute coronary syndrome and chronic coronary syndrome. So this is actually published in the European Heart Journal and European Society of Cardiology last year, but they have not still made their way into the guidelines as far as to my knowledge. So this new classification hopes to be more inclusive of the non-obstructive causes of coronary artery disease. So the thing about it is, now when you say acute coronary syndrome and chronic coronary syndrome, it always reflects that this is a pathology in the coronaries.
Yeah.
But it's not always so, because suppose in a patient that is extremely anemic, let's say hemoglobin about 5, they can still have a myocardial oxygen perfusion mismatch causing ischemia in the absence or in the presence of normal coronaries. So this new classification, or rather new nomenclature, aims to rename acute coronary syndromes as acute myocardial ischemic syndrome versus non-acute myocardial ischemic syndrome instead of chronic coronary syndrome. So this hopes to be more inclusive of the non-obstructive coronary pathologies.
Right. So I think about a year ago, while I was doing an MCQ, I came across this term type 2 MI in one of the stems. And at the time, I have never heard of this term. So I thought someone must have, memorized it incorrectly or something of that sort. For the rest of our listeners who might not be aware of that classification, what is these types of MI? Right.
So to make things even more complicated, so you can again reclassify acute coronary syndromes or acute myocardial infarction into 5 types. So that's type 1, 2, 3, 4, and 5. So type 1 is when the usual thing that we talk about. So acute coronary syndrome secondary to acute thromboembolic changes in the coronaries. So, and type 2 is what we actually talked about earlier, where there is a mismatch in oxygen demand versus oxygen supply because of lowered perfusion, or in patients that are extremely anemic, in the absence of acute coronary thrombosis. Yeah. So type 3 is to simplify it, sudden cardiac death because of a coronary event. Type 4 is when the coronary event is related to or is in the around the period where patient has undergone a percutaneous coronary intervention. So this can be subclassified into 3 types. So type 4B and 4C involves coronary thrombosis and coronary restenosis. I won't bore you with the details again, so you can go through this classification and see. So, and type 5 is basically after a CABG, within the first 48 hours after a CABG, they can again have coronary events. So this is another way of classifying, but out of these 5, the more important things that you will see as an internist on a daily basis is type 1 and type 2. We do see a lot of those.
Right. So Mr. Zoysa will probably be having a type 1 MI in this case.
Yes, he is possibly having a type 1 MI because he has all the traditional risk factors that you associate with a coronary atherosclerosis.
Yeah. So coming back to Mr. Zoysa, as I mentioned, he was diagnosed with diabetes, hypertension, and hyperlipidemia for 5 years. And he has had poor compliance to lifestyle advice and medication. He is an avid beer drinker and ex-smoker with a 10-year pack history. And on examination, he appears obese with a BMI of 26 kilogram per meter square. So as you mentioned, Mr. Zoysa does have many of those traditional risk factors like diabetes, hypertension, and hyperlipidemia. But apart from these well-known sort of risk factors, what are the lesser-known culprits for ACS?
Right. Just to recall, I think you mentioned that Mr. Zoysa was 40 years old,
yes.
Right? Right. So that itself is a really, red alert sign. So yes, as you said, so traditional risk factors would include your diabetes, your hypertension, and, smoking and sedentary lifestyle and, alcohol consumption and so many other well-known risk factors. But especially in the young patient and more so in the young female coming with an acute coronary event, you do need to consider the possibility, in the absence of these risk factors, you need to probe further to find some less known risk factors for acute coronary syndromes. So to give a very brief overview, any significant chronic inflammatory state does raise the risk of atherosclerosis because atherosclerosis is fundamentally linked to inflammation. And so one other common risk factor that we see is chronic kidney disease. So they have they have a coronary atherosclerosis risk independently higher just by the fact that they have a chronic kidney disease. And some other less known factors also involve hypohomocystinemia and as such. And one very important thing that we tend to sort of overlook sometimes is in anybody that is presenting with a young onset acute coronary event or chronic coronary disease, you need to consider the possibility of familial lipid disorders that may or may not be genetically inherited, most of the time genetically. So this can be familial hypercholesterolemia and as such. But I would like to place one more key thing, which is lipoprotein A. So lipoprotein A is very much implicated in coronary and atherosclerosis elsewhere. So the important thing about it, it's not detected on a normal lipid profile. So just by doing a lipid profile, you might not ever know whether the patient has a high lipoprotein A level or not. And a very peculiar thing is lipoprotein A shows very minimal fluctuations during lifetime and it is genetically inherited. And so measurement of just at least once you need to be checked for lipoprotein A if in a patient you're suspecting with in the absence of the usual risk factors. And so anybody that has had an acute coronary event needs to be established on lifelong high intensity statins. So this involves either a dose of atorvastatin 40 to 80 milligrams or a rosuvastatin 20 to 40 milligrams. But there is so much interest in newer forms of lipid lowering therapy, and some such drugs involve PCSK9 inhibitors and this drug called inclisiran, which are widely unavailable for us because of the cost. but they are also possibly not available in our current health sector. So, and there are certain alternatives to people that are also intolerant to statins, like bempedoic acid has been, recommended, as well as this drug called ezetimibe. So that is what you call this very weird class of lipid lowering therapy, what you call the Niemann-Pick C1 like 1 receptor antagonist. So it inhibits cholesterol absorption. So it has a very interesting action where it is very synergistic with statins. So it is very potent in reducing LDL when combined with the statin. So in patients that you can't get the LDL cholesterol down enough, so what the recommendation is a less than 55 if they've had at least one acute coronary event or cardiovascular event in the past. But if they've had 2 events within the span of 2 years, then that LDL target should be less than 40. But as we all know, Asians are at a higher risk as baseline. So the LDL cutoffs may need to be lower than the less than 55 or the less than 40 that is recommended by the Western guidelines. Going back to lipoprotein A, the other important thing is statins don't seem to have a lot of effect in reducing lipoprotein A levels sufficiently to reduce risk. So this is where again PCSK9 inhibitors seem to come into play, drugs like evocolumab, which are administered subcutaneously 2 to 4 weekly, so that also improves compliance when it comes to patient care. So these seem to have a fairly significant effect in terms of reducing LDL as well as reducing lipoprotein A. But it might be some time before we get these drugs down. So, but it's very interesting part of medicine and lipid disorders. So I urge you to read up on that.
Right. So let's assume that within sort of 10 minutes of presenting, we get Mr. Zoysa's first ECG. So you turn around and hand it to me. What are the ECG changes I should look out for?
Right. I do love handing out ECGs to students. So you need to have methodical way in interpreting ECGs. There has to be a method to the madness. It can be quite complex. It's very daunting. It's very challenging, especially in your early years of medicine. It still is challenging for me sometimes. But in the conversation of acute coronary syndromes, once you've ruled out, once you've looked at those P waves, the QRS, and the RR intervals, and the rate of the paper speed, and all those things, you do need to hunt for an ST elevation. Right. Because hunting for that ST elevation is fundamentally important because it signifies transmural infarction of the heart. So in the presence of ST elevations, it really does expedite and change your patient care. So which we hope to talk about later in the next episode. So an ST elevation is significant in any lead apart from V2 or V3. If there's even a 1 millimeter deflection is significant apart from V2 and V3. But there are other age and gender specific cutoffs when it comes to the elevation in V2 and V3. For instance, in females, regardless of age, a greater than 1.5 millimeter elevation is significant. While when it comes to males, whether you're less than 40 or greater than 40, so in less than 40 years, a greater than 2.5 millimeter versus a greater than 2 millimeter elevation in greater than 40 years is significant. So you need to know that cutoff. And keeping in mind that not all ST elevations are associated with, or other acute coronary syndrome or transmitted infarcts of the heart are not the only cause of ST elevations. So it can sometimes be Prince metal angina, which is vasospasm of the coronaries, and myocarditis, pericarditis can also cause ST elevations in the heart. And sometimes left bundle branch block can be associated with ST elevation. It's very difficult to differentiate the two. So there's different criteria to interpret an ST elevation in the presence of a left bundle branch block. And sometimes ST elevations are caused by pathologies that are completely unrelated to the heart, such as subarachnoid hemorrhage. And also, in any patient that is persisting to have an ST elevation in an ECG beyond 2 weeks, you need to also entertain the possibility of an apical aneurysm. Apart from this, one very interesting thing is this entity called Takotsubo cardiomyopathy. It is also a known cause for ST elevations in the heart, in the ECG. So you need to keep all these things in mind when you are looking at a patient. But so this is why it's extremely important to correlate the ECG with the patient history.
So we have now obtained the ECG, and I have gone through looking for ST elevations. So apart from these ST elevations, what other ECG changes should I be on the lookout for?
Right. So as we talked about earlier, the presence of ST elevations does really change your, scheme of management. And so there are also, in the absence of ST elevations, you need to also look out for some changes that might not have ST elevation, but they are known as STEMI equivalents, ST elevation equivalents. So some of these changes are, I think you all know, hyperacute T waves. So hyperacute T waves indicate evolving ST elevation acute coronary syndromes. So it's important to look at hyperacute T waves. And as I mentioned earlier, left bundle branch block is something that would sort of mask ST elevations in the heart. And any new onset left bundle branch block which is not present on a previous ECG needs to be considered pathological, and sometimes may warrant treatment in the same lines as an ST elevation ACS. But if the patient has had a left bundle branch block in the previous ECGs, there's this thing called this Garbosa criteria, and lately the Smith modified Garbosa criteria that you have to use to see whether the ST elevations in an old left bundle branch block are now significant enough for you to warrant as management of an ST elevation ACS. And the other few things that you need to consider as ST elevation equivalents are the posterior ST elevation MI, which manifests as ST depressions in the anterior heart. So that might tend you to think that this is a non-ST elevation or an unstable angina, but the presence of anterior ST depressions requires you to do posterior leads to look for posterior ST elevation changes. And the other maybe less known entity is what you call the D Winters, the D Winters pattern. So all these are hyperacute T waves, left bundle branch block with or without a positive Garbosa, and the posterior ST elevation changes and the D Winters are considered to be ST elevation equivalents. So you may need to expeditiously manage these patients. So I hope we can get some of these ECGs on the show notes so that people can go through these. So once you've ruled all these ST elevations and ST elevation equivalents out, then you go into your looking at the acute and the subacute causes for coronary thrombosis. So these manifest as your ST depressions, your T wave inversions, and as such. But there are also a few more changes, two in fact, that I would like to place with you today, which is the AVR ST elevation MI and the valence sign. So the AVR, if there's an ST elevation in the AVR lead, we tend to think of it as three differentials for this particular change. So one is severe triple vessel disease, diffuse subendocardial ischemia, and a left main coronary artery occlusion. These are all quite sinister pathologies that may require early PCI. The other thing is what you call the valence pattern, which indicates a proximal left anterior descending occlusion. So these are again quite sinister patterns in the ECG that you need to make note of when you are going through ECGs. I know this seems like a lot, but there's this, the American College of Cardiology, that they have this paper called the Consensus Decision Pathway on Evaluation and Diagnosis of Acute Chest Pain in the Emergency Department. I think it's best if we can leave that in the show notes as well so that people can go through it and maybe read about this a bit more. But apart from all these changes, the ST segment deviations, you need to keep an eye out for heart blocks, arrhythmias, either tachy or brady, because arrhythmias are some of the most common causes for death after myocardial infarction. You need to keep a lookout for that as well. Yes, so that's basically how you would approach an ECG.
Right. So all of those things that Dr. Sarith mentioned will be put down in the show notes for you all to go through. So make sure to look at that at the end of the podcast. Right. So Mr. Zoyser did not have any of these alarming ECG changes. Where would we go from there?
Right. So in the absence of all these ECG changes, then you're going to push me into a tight spot when it comes to diagnosing acute coronary syndrome. So it's important to realize that the history is possibly the most important thing. A suggestive history in the absence of ECG changes still requires, confirmation of an ACS, exclusion of an ACS. So you need to get a hold of a good history to begin with. But if you want a tiebreaker between the two, whether it's ACS or not, the next thing that we do is a troponin. So troponins are diagnostically important, and they also are important in risk stratification, but they are not essential in the presence of an ST elevation in the ECG. So an ST elevation MI does not really require troponin for you to decide on management. But in the absence of ST elevations, you might have to look at that troponin to make sense of it a bit more. So the troponins are also now evolved over generations. Now we use the latest ones, I think, are the 4th and 5th generation troponins. And back in the day when we thought about troponin, it was either a positive or a negative value. But now with the latest generations of troponins, what we call the high sensitivity troponins, these are extremely sensitive. And what we get now is a titer. So we get an actual number about the level of troponin. So because these are extremely sensitive, we are now able to detect even baseline plasma levels of troponin. So now this has sort of made this a bit more complicated and complex in terms of interpretation. And this has also led to overdiagnosis of myocardial infarction sometimes. So to make sense of the troponin, I would like to direct you to what you call the 4th iteration of the universal definition of myocardial infarction, where it mentions that troponins are best tested as serial tests. So this is also endorsed by all the major guidelines, the American College of Cardiology as well as the European Society of Cardiology, where they recommend a serial troponin level at 0, 1, and sometimes the second hour troponins. So we are no longer restricted to checking for a single troponin. What we are interested in now is what we call the troponin kinetic, the kinetics of troponin change. So where we look for variations in troponin to make sense of what's going on. So based on the universal definition of myocardial infarction, what it asks for is for a troponin to be significant, what we are looking for at least a single value being greater than the 99th upper reference limit, and with either a rise and or drop in the troponin considered to be significant. So it's not only a rise in troponin but also a drop in troponin that we always need to think of as significant, because an acute drop and or acute rise and or drop signifies acute myocardial damage. So versus a chronically elevated level of troponin with very little delta change, so there are values that you use to gauge this, signifies chronically elevated troponins because of either a chronic myocardial problem or else sometimes so many other causes that can cause chronically elevated troponin. So it's important to look at the first and the second hour troponins and then decide on whether you are going to rule in or rule out an ACS. So this is what all the guidelines seem to converge on now in terms of interpreting troponin. And so yes, and mind you, it's very important to, again, I want to stress this as much as I can, troponins should not be interpreted in isolation. They need to be put in, they need to be incorporated into the history as well as the ECG of a patient to rule out or rule in acute coronary syndromes.
So troponin seems to be this sort of investigation that has developed over the ages, from being just a static test that is either positive or negative to this dynamic test that provides us with titers. Right, and one thing I want to stress on is there was this mention about there are many other causes for the elevation of troponin. And this is a very common question in exams as well as in ward rounds. Can you elaborate a few of those causes for elevated troponin?
Right. This again brings me back to the whole point about how sensitive the recent troponin assays are. So they're extremely sensitive. So even the most subtle changes in myocardial function can be reflected on a troponin. So as you mentioned correctly, Vishal, it's not just necrosis of the heart that leads to troponin rise anymore. So it can be myocarditis, it can be even sepsis, even shock, anything that causes a tachycardia can raise troponin, respiratory failure can raise troponins, and heart failure is very well described, and even sometimes severe hypertension can raise a troponin level. So now what we have gotten ourselves into is a position where we need to really incorporate that clinical history and ECG to make better sense of troponin so that we don't overdiagnose myocardial infarction. So troponin elevation can be then either an indicator to myocardial injury and not always myocardial infarction. So it can just signify myocardial damage. So it is only in the correct clinical context that this signifies infarction. So you need to really pay attention to that history and history examination and ECG. This sort of encourages the concept that you should only test for a troponin in a patient that has a high pre-test probability.
Right.
So in the absence of a high pre-test probability, the chances that you might end up with a wrong interpretation of a troponin is also high. So you need to be very selective about how you do troponin. So not every patient requires a troponin. So you need to have that in mind when you're doing a troponin level.
Right. Something that stumps me quite often is that there are these multiple non-cardiac conditions that contribute to a rise in troponin, like respiratory failure, chronic kidney disease, and so on. And like you mentioned, these assays that we have now are highly sensitive and also quite specific for cardiac troponin I. What confuses me is how do these non-cardiac conditions contribute to a rise in a cardiac enzyme?
Right, so that's a very good question. So now troponins, as we know, so now we are again, we have such sensitive assays, we have different cutoffs based on gender as well. So the females have a different cutoff for elevation, so upper reference limit, and the males have a different cutoff. So that's how sensitive the troponin assays are now, and these are being widely used even at our healthcare setting. So back then we always thought of a troponin elevation indicating myocardial infarction, cell necrosis, and release of these biomarkers. But now we understand that it's not only the cause for a troponin elevation. So there have been there's enough and more literature to support that myocardial apoptosis, so due to caspases cleaving out structural proteins, basal levels of myocardial cell turnover during the lifespan, myocyte cell membrane disruption and increased cellular permeability, which can result from even myocardial stretch and not just ischemia, will elevate the levels of troponin. So if you want to know more details about this, again, something that I would ask you is, there's this paper called The Clinical Interpretation of Serum Troponins in the era of high sensitivity testing, that I think we'll possibly be able to leave in the show notes again so that people can read this up a bit more.
Right. So I think we have become sort of too good at looking at troponins.
We are a bit concerned.
Right.
Yeah.
Right, so that brings us to the end of a really engaging conversation with Dr. Sarit. And before we sign off, could you share a few key takeaways for our listeners to take home?
Right. Again, one more thing I forgot to mention. So, going back to the troponin, so we have become too good in detecting levels of troponin, but this also is, the advantage of this is because it's very sensitive, we are very much able to rule out ACS early on. So a negative test really indicates a very unlikely acute coronary. Acute coronary events become very unlikely in the presence of negative troponin, assuming that you've done serial troponins. So that's the advantage that we've gained by having very high sensitivity test. Right. So to answer your last question, yes, the key takeaways. I think evaluating chest pain can be tricky. A risk factor weighted clinical likelihood model is quite important and can be useful. And history is fundamental when differentiating acute coronary syndromes from chronic coronary syndromes, and it is imperative for a diagnosis of myocardial infarction. I would ask you to read about the universal definition of myocardial infarction, the 4th iteration of it. And non-traditional risk factors need to be explored in especially the young patient coming with acute coronary syndromes. And be mindful of ST elevation equivalence in the ECG. It's not just ST elevations that signify transmural infarction. And troponin elevation should always be interpreted in the correct clinical context. So in a compatible clinical history and with compatible ECG changes, that's where the troponin really shines. But when you put it in isolation, there's a very good chance that you will be misled. So do troponins when there's a high pretest probability. So a very high sensitive test has been very useful in excluding ACS. So these would be my key takeaways. Yeah.
Right. So thank you very much, Dr. Sarit, for joining with us with our debut episode at this podcast channel. And I would ask for our listeners to stay tuned with our podcast channel as we bring you the second part of this podcast, which will be focusing on the principles of management of acute coronary syndrome. I also urge you to go through our show notes, which will contain a lot of the sort of material that Dr. Sarit referred to. And if you are interested in watching the video format of this will also be uploaded at the University of Colombo Clinical Society YouTube channel. So stay tuned for that. Thank you for listening, and we'll catch you in the next one.
Yeah. Oh, that's okay.